Request everyone to please maintain silence. Respecting the speakers is also the first important thing, so please maintain silence. And I'm sure you'll be having a very great session.
Thank you so much. Thank you, Rahul sir, for another comprehensive talk on the critical care aspects. You're always welcome. And primarily, I would like to thank ISCCM, my association, Jupiter Hospital, my head of department, our CNO, Shine ma'am, and all of you for providing me with this opportunity to talk on the approach to cardiac arrest. So primarily I will be focused on the science of cardiac arrest in this session. I will just rush through it, and after lunch we will discuss on the art of managing cardiac arrest. Right? So I know hunger time, but this should be a more hunger time, the hunger to know how to revive someone. Right? So with that spirit, let's move on. First of all, I'll keep moving so that nobody sleeps, but I won't maintain a pendulum movement, otherwise you'll get hypnotized. Anyway, so let's talk about the general concept of managing cardiac arrest. As you can see, you need to initialize the chain of survival. Not a single person can single-handedly manage any emergency event. So you need to have a chain of survival established. You need to perform a high productive CPR. We'll learn all about that in the later session. The early use of AED is advocated. For what purpose? These miraculous recoveries that we keep hearing, listening, reading about, that such and such a patient collapsed in the garden, somebody collapsed on the airport, and they were revived. So these are those small percentage of patients which can have a miraculous recovery, provided they are attended to immediately. For example, I collapsed right here at this very moment. There's a hospital next door, correct? Can you assess the time that you might require to take me to the hospital? Maybe 5 minutes. Suppose if I crash here, you pick me up and you run, you'll take how much time? 10 minutes? Okay, so international data is every 1 minute lost in starting CPR is equivalent to 7% of loss in attempting the patient to revive and send the patient walking home. You might be able to revive me, but you're not sure that you'll be sending me walking home. Getting the point? The neurological aspect of resuscitation. So, and even though the hospital is next door, but 70% chance of my survival is already lost. Survival and you sending me walking home. So that is why we need to immediately assess and we need to establish the chain of survival. So outside the hospital we have this chain that you need to activate the emergency response. You need to provide high quality CPR, defibrillation if advocated, advanced resuscitation, post cardiac arrest care. And since 2020, AHA has included this as the last, but this should be the first, the thought of recovery and sending the patient walking home. Clear? Inside the hospital, we again have these similar links. The only difference is early recognition and protection. Ma'am earlier had spoken about the MUSE. We here follow the PAR score or the patient at risk score. We have the various physiological characteristics based on which we determine which patient needs to be shifted to a higher area of care. Clear? So what are the principles? 4 primary principles. You need to establish unresponsive. So how many of us are responsive right now? Slow. That was pretty slow. So establishing unresponsiveness. Can I have examples? Where you might find a patient unresponsive? Patient, not us. There are various factors, right? Stroke, hypoglycemia, so many things. Saturday evening, Sunday morning. So that patient might be unresponsive, but definitely not requiring CPR. So you need to determine the unresponsiveness and you need to immediately start providing oxygen to the brain. You need to maintain circulation to do that and you need to defibrillate early. Those miraculous recoveries we spoke about. So there is something called as a systematic approach to basic life support that we follow. It is the foundation to every algorithm determined by the American Heart Association or any association which carries out the resuscitation attempts. It is a first step in every emergency, and it comprises of 4 main steps. What are those steps? Check responsiveness by tapping and shouting. That is verbal as well as manual this thing. And activate the emergency response system and obtain an AED. This is very important. You may have the people, but if you don't have an AED at least, you won't be able to get this miraculous recovery kafanda. Right? You read all these papers. They have the AED around, somebody has attached it. Need not necessarily be a medical person, even a common man can do that. And these patients are revived. You need to check for a carotid pulse over 5 to 10 seconds. If there is no pulse, immediately start chest compressions. And the fourth one is defibrillate if your AED is available or your defibrillator in the hospital is available. Supposing you have a defibrillator which is available in the hospital, but you are not able to analyze the rhythm. Each defibrillator nowadays has an AED mode. Switch it to AED mode, use it as an AED. Clear? So let's define cardiac arrest. What do we mean by cardiac arrest? Definition पढ़ लो. So it's basically mechanical and or the electrical activity of the heart that stops. It is characterized by unresponsiveness and a loss of breathing and pulse. So your Sunday morning patient may be unresponsive but will be breathing and will have a pulse. Correct? So you need to determine this. So how does the heart stop in cardiac arrest? By 2 means. One is by totally going into a mechanical loss of activity, where there is absolutely asystole, that is a flat line. Movies mein jisko shock karna dikhate hain, but that is not a shockable rhythm. And on the other side, you have the shockable rhythms like ventricular fibrillation and pulseless ventricular tachycardia. Clear? So, before you attempt any resuscitation, what is very primary? Scene safety, because that is also a part of establishing the chain of survival. If you initiate CPR, you continue for maximum, maybe youngsters around here may continue for 5 minutes. What happens after that? You will get exhausted, you will tire yourself out, and the goal will not be achieved. Second step is you check for unresponsiveness. Third step is you get early access to your emergency response system. Inside hospitals, we have the code blue system. We have a dedicated number which can be reachable from each and every extension. And outside the hospital, in India, we have the 108 system. Right? You can communicate with them. They'll guide you with regards to TCPR on the phone itself. Yeah. Check for pulse and carotid pulse and breathing. But believe me, even after 25 years of critical care experience, I cannot say that in an emergency you will be able to determine the presence or absence of a pulse in 5 to 10 seconds. Everyone agrees with me?
Yes.
Right? So the criteria primarily becomes a patient not responding and not breathing. Correct? So if you are able to determine the absence of pulse, you immediately start off with the CABD protocol recommended by the American Heart Association, which was earlier on was ABC, airway. All of us old timers used to run at the head end to put in a tube first, without realizing that even if you put in 10,000 liters of oxygen, there's no mechanism which will make it reach the brain. Right? So compression eventually became the top priority, followed by maintaining an airway, providing access and support to breathing, and defibrillation if required. Correct? So once you have followed these steps and this patient does not follow these criteria, or you have initiated your BLS approach, systematic approach, next thing that you do is carry on into the advanced cardiac arrest care approach. It again has got a ABCDE kafanda. First one is maintain an airway and use an advanced airway if needed. Why are we mentioning advanced airway right in the beginning? How different it is from a regular bag masking? It provides a closed circuit, which can be connected to your EtCO2 and it will reflect on the quality of CPR that you are providing. Second is you give bag mask ventilation. Even with a bag mask, if you have a proper tight seal, you can still have a closed circuit, right? With the impedance threshold device and all those things. We will not go into the details. But what is important is you need to avoid excessive ventilation. Now this is a very important point. All of us must have gone through or have been a part of resuscitation somewhere. Just recollect that moment when somebody is giving chest compressions and somebody is managing the airway. If you look at the airway person, the zeal and enthusiasm is so high that he tries to match with the compressor in providing bag mass, right? That is a good will, but it is non-productive. So you need to avoid excessive ventilation. You have to have your ratio determined that every 5 to 6 seconds is only one breath that you have to give. Next is circulation. You have to obtain an IV access early. You need to attach the monitors and you need to know the arrhythmias, if at all. Correct? Then perform a general neurological assessment, the AVPU scale, pupils, sugar, to determine whether this patient is responsive or not, and expose the patient for 2 primary reasons. What is the first reason that you need to expose this patient for? Pardon? Most important thing that you require to expose this patient for? For, yes, defibrillating this patient if required. And also look for injuries, your bands, identification bands, or your do not resuscitate bands and all those things. And that is why a proper assessment and obviously injuries. Correct? So this is the circular algorithm. As an ACS team, we are helpless until we follow or we have these 3 instruments or weapons with us. What are the 3 weapons? Provision of oxygen or respiration support, provision of IV medications, and the use of defibrillator. Correct? So we have this circular algorithm where we continue CPR for 2 minutes, we analyze the rhythm, we shock if required. Immediately after the shock, we start the compressions again. In between, there are various factors that you provide epinephrine every 3 to 5 minutes. The use of amiodarone or nowadays lidocaine has been introduced. We'll see all this in the training session or class. This is the actual algorithm where you start off with epinephrine, shock, 2 shocks, 3rd shock, another epinephrine in between. After the 3rd shock, you have amiodarone, the first dose. Then again, if the rhythm is shockable, you will continue with epinephrine, another dose of amiodarone, if required, lidocaine. This is the actual algorithm, you can find it on the net. So what is the actual algorithm? Or what are the points that we need to cover on? High quality CPR, the use of shock energy, drug therapy, advanced airway, the overview or a look into the reversible causes, and the return of spontaneous circulation. What happens? Revive कर लिया, rhythm आ गई, बस हो गया, ICU में shift कर देते. That is a common answer we derive or we get when we ask, अब क्या करेंगे? Rhythm आ गई है, there is an organized rhythm, there is a pulse present. There are few things that need to be done even after that, before you call it a day. Clear? So regarding high quality CPR, we know that you have to push hard, push fast. How hard? 5 centimeters. 5 inches. Adequate enough to squeeze the heart in between the spinal cord, bone and the sternum. Correct? Adequate enough, because see what is happening, you have to provide a cardiac output. कितना भी जोर से squeeze किया तो you are not going to provide 1/4 of the actual cardiac output. Correct? So considering a normal heart rate of 70, AH has determined that you have to push at least how fast? 100 to 120. So at least you can have half the cardiac output generated. But if you go on squeezing uninterruptedly, what's going to happen? Your first few squeezes are going to empty the heart. What else are in empty heart? So you need to allow recoil, you need to minimize the interruptions, you need to avoid excessive ventilations, and you need to know your ratio. And if you have an advanced airway in, you have to have a ETCO2 attached. That will be an indirect verification of your quality of CPR. If it is less than 10, you'll have to improve on that. Or if you have already an arterial line in place, a measurement of 20 mm or less is also an indication. And this again becomes an indication the moment you reach ROSC. The ETCO2 immediately jumps from 10 to 40. Correct? So it is not just an indication of your quality of CPR, it is also an indication of the productivity and your result of CPR. Clear? Use of shock energy, we know if we have a monophasic machine, we use 360. If we have a biphasic machine, we use the 200J. subsequent increase in further dose. That is why I mentioned this here, is because if it is a perfusing rhythm that you are managing or a near cardiac arrest situation. Clear? Do not interrupt the compressions, analyze the rhythm, and there is a significance of these pads. Now supposing we have a child who is 7 years old and you have attached the defibrillator and it is telling you that it is a shockable rhythm, but you don't have the child pads. What do you do? Do you shock this rhythm or not? Yes. How many yeses? How many yeses?
Yes.
How many yeses? Let's see your hands. Rest of you, why do you feel we should not shock a shockable rhythm? That is really shocking. If it is a shockable rhythm, it has to be shocked. Otherwise, your heart is not going to get out of this vicious circle, The only difference is the child might take some time in convalescence because of the high energy that it received. Simple example, we all have kids around in our house, apne relatives ke. You've seen them wearing ass slippers and moving around. Can we do the same? Of course, but we won't be able to walk. So, if you have adult pads, you can use it on a child. Converse is not true because that energy will not be sufficient for an adult. Yeah, so remember this aspect. I felt the need to talk about it at this point. Going to advanced airway, as I said, you need to have these devices. Some are blind insertion airway devices, which will provide you with a closed circuit. And that connected to ETCO2 will provide you the information necessary. Correct? Plus, you have your ETCO2 which will give you the confirmation of placement of the tube. You put in a tube, you give a few bag masks, you give a few bag ventilations. How many ventilations will determine you are not in the esophagus? One. Stomach gas has CO2, right? So if you depend on one, probably that might not be sufficient. Look at the name, quantitative waveform capnography. Quantity is the quantity of CO2 that you will see on the screen. Waveform capnography. When will you get a wave? It's only when that you have a closed circuit and it is continuously providing the same pressure gradient. Your tube in the stomach, 1 or 2 readings you will get, after that you won't get any waveform. But if your tube is in your lungs, which is a collapsible organ, you will be getting a good waveform. You will be getting a good wave and a good recording. And it helps in monitoring. You need to provide one breath every 6 seconds. Clear? IV access. These are the cardiac arrest drugs that we use. Epinephrine, the dose of 1 mg every 3 to 5 minutes. Amiodarone, the first dose is 300 mg. The subsequent dose is half, that is 150 mg. And lidocaine if required after amiodarone in case of a shockable rhythm. If it's a non-shockable rhythm, it is what? What is the algorithm say? Epinephrine, epinephrine, epinephrine and compressions. Clear? Right? And magnesium sulfate if your rhythm is a torsades. And what if you don't have an IV access? You must have seen in the video. Within 3 seconds, the IO gun can help you get an intraosseous access in case of a cardiac arrest. If not, again here your advanced airway comes into play, where you can provide cardiac arrest drugs in high concentrations diluted with normal saline through the endotracheal tube itself. You will have to give a few excessive ventilations so that the drug disperses in the system. But again, your ET comes to help even at this point. So, along with your primary assessment of advanced cardiac life support, you have something called as a secondary assessment or the sample history. Signs and symptoms, what happened, since when, was it a CKD patient, like the example we had in the mute code, or if you have any known allergies, if there is a history of past medications, patient on beta blocker comes with a bradycardia, something like that. Past illnesses, they will give you an idea, patient is a known COPD or has a history of recurrent SVTs or arrhythmias. And the last oral intake, that helps you in determining how reliable you can be on this airway, or do you immediately put in a tube and avoid aspiration as a secondary complication. And the events leading up to the present illness, what exactly happened, how it happened, that gives you additional information. Clear? Then you look at the probable causes of the non-shockable rhythm. This goes into more detail because as we saw, miraculous recoveries are those shockable rhythms which you have immediately shocked out. But these other patients, these chronic patients lying on your ICU beds, there may be various reasons out of these. So moment one of these patient goes into cardiac arrest, you have to start thinking, and it is a non-shockable rhythm, you have to start thinking about loss of volume, whether this patient has bled, hypoxia, whether this patient has been chronically off ventilation support, hydrogen ion acidosis, hypo and hyperkalemia, and hypothermia. And the 5 T's are tension pneumothorax, tamponade cardiac and coronary, toxins, thrombosis pulmonary, and thrombosis coronary. So the reason for cardiac arrest in a non-shockable rhythm cannot be anything out of this. Clear? So at a glance, supposing you have revived this patient, what do you need to optimize, or what we call as a post-cardiac arrest care? You have to determine ventilation and oxygenation, whether it is proper. You have to bring up the saturations. Here, these are 2 important points. We don't want to see the good 100% saturation ka figure here. Correct? Why? Why don't we want to see the 100% oxygen ka figure on the monitor, cardiac monitor? Yeah, so you have started resuscitating and your ROSC has been achieved. Patient is out of cardiac arrest. We don't want 100% oxygen in this system. I can understand there is a lack of oxygen now, but is it not a drug? Is oxygen a drug or no? Does it have effects? Does it have side effects? Exactly. Oxygen toxicity, importantly vasoconstriction. Correct? So you don't want a good 100% oxygen ka figure. Any saturation above 94, 95 up to 98 is fair enough. In other words, again, you don't have to be very aggressive in ventilating this patient. More important is building up the hemodynamics. If it's a person where you expect or suspect volume depletion, you give fluids. If supposing it's a CKD patient who's gone into cardiac arrest, you have your sample history, you will not start fluids to this patient, you will go ahead with inotropes and try to bring up the blood pressure, right? So it helps you in permutation and combination in determining what steps to take. Clear? Then vasopressors, dopamine, and a thought about the reversible causes. Unless and until you treat the reversible causes, your patient is not going to get out of cardiac arrest in case of a non-shockable rhythm. Clear? So you can remember it in this way: A, B, C, D, E, F, G, H, I. Once your patient is revived, you check whether this patient is conscious enough and maintaining his airway. If not, you provide secondary help by intubating or taking this patient on bag mask. You check whether this patient is breathing or not. If not breathing, you'll have to ventilate. You look for the circulation, what steps you need to take to bring up the blood pressure. The drugs, what this patient was on, what this patient is going to require. ECG, that will help you determine what step to take next. Fluids, sugar levels, hypothermia to be introduced. In cases where your patient is not responsive, there is something called as targeted temperature management that we need to initiate. Correct? And investigation and invasive lines that you have put in emergency, are they all functional? Are they all well in place? You need to determine all these things. Correct? So, you have done your ECG. This patient has an ST elevation MI after resuscitation. What will you do? Activate the cath lab. Because if you don't, this patient is going to go into cardiac arrest again. So your ECG has helped you determine what to do. Targeted temperature management for at least 24 hours. Prevention of fever. Identification and correction of hypotension, because then all your other organs, vital organs that have remained hypoperfused for so long time, they are going to go into dysfunction. For example, acute kidney injury. Correct? So you'll have to bring up the blood pressure and maintain hemodynamics. Prognostication after 72 hours of completion of targeted temperature management, where you start normalizing the temperature and you reassess this patient, whether this patient is neurologically active or not. Last but not the least, such patients need to be considered for potential organ donors. Correct? This is a neuroprognostication chart. You can see it on the net. What all steps that can be taken at the end of 24 hours, 48 hours, 72 hours to determine whether this patient will be able to get revived neurologically or whether we start counseling the family for organ donation. Correct? So answering the $1 million question, when do we stop CPR? Any answers? Yes, when there is an ROSC achieved, obviously patient is not going to require CPR. Any other indications for stopping CPR? Exhaustion. That's why chain of survival. Where else? Where else? Okay, tell me, where will we start CPR in the first place? Or where will we not start CPR? That we start CPR. But a patient with no breathing, no pulse, and you don't want to start CPR? Any indications? Exactly, a very beautiful point. If you don't know the science and art of providing CPR, that's why we have come here today and met on this. So you need to know, there are many instances, I've heard so many doctors calling for doctors in the event of an emergency. So you need to know how to provide CPR, what needs to be done. That's when we won't start. Injuries which are non-compliant with life, a beheaded patient, you will not start CPR. Correct? And when will you stop? These are three primary indications.
Quality of life is not going to improve in spite of giving
We usually in India don't follow this. We don't have the DNR facility here where I decide I don't want to live, or where my relatives decide. CPR.
half an hour of giving the result.
Yeah, so yeah, I wanted that figure actually. So is it half an hour?
Half an hour.
Is it 45 minutes? 25 minutes. So
In spite of the resuscitative
yes. So the determinant here again becomes your ETCO2. If you have your ETCO2 in place and your capnography waveform is not showing an improvement above 10 for more than 20 minutes, it's about time you call it. Clear? And supposing this patient is not arrested in front of you. You don't know what the situation was at the time of arrest. Patient has been brought. Relatives come in wheeling in a patient. They say, "Abhi to saans le rahe the." That could have been an agonal gasp. And we know 10 minutes इधर से next door को जाता है, तो somebody coming from outside the campus definitely might be coming after at least 10 to 15 minutes or 20 minutes. So this probably patient will not be able to get resuscitated. Third thing is, if it was not a shockable rhythm at presentation. See, what happens is when the heart starts failing, it goes into a quivering phase. And when this quivering phase is extended for a prolonged period of time, the myocardium fatigues and there is a total asystole. Correct? As it is a progressive, a non-shockable rhythm is a progressive stage. So if your patient is coming to you at that stage, probably you won't be able to revive this patient. So these three things are important, and something to help us remember how CPR is to be done. So look at his approach, determining scene safety. Now he's checking for response. That's not the correct way, but will help us remember. So this is the best thing that he's doing. He's calling for help. So the best thing that he can do is give CPR rather than not do anything. Obviously not the right way of opening the airway. Yeah, so he has devised a different way of doing it. But remember, chest compressions are important. So mouth to mouth sounds very glamorous, but you would not usually prefer, especially after COVID. So medical accepted way of providing ventilation and oxygenation. Specialized equipments. We have our pocket mask. He has his magazine. So tight seal, following to see an adequate chest rise, not hyperventilating. So avoid that excessive ventilation, right? And allow chest recoil. So by this time, your help must have arrived. I think he's found adrenaline tablets. Are they available? Know your equipment, how to open that bottle. Refill का पैडल्स ऐसे मत खींचना. Right drug, right route, right patient. Shake well after use. So what remains? What remains in the 4 steps? Shock, providing shock. So he finds a automatic external defibrillator around. No matter what the shock energy is, providing shock is important. Doesn't work. Second shock doesn't work. So this is a miraculous recovery out of it. Reconfirming unresponsiveness or rather responsiveness. The safe use of equipment is also important. Once you are given the shock, kindly cradle your pads. And get rid of all evidences. क्या हुआ? कुछ भी नहीं. Yeah, done. Next. Right. So thank you all of you. Thank you so much. So that was the why and regarding the how we will be talking about it post lunch. So sleep well.